But once patients are there, it's still very hard to make the therapy happen in a timely fashion. So again, these are hospitals that we're trying to get with the guidelines to meet the 3-hour window to get as many people treated as possible. And same set of patients, about 12,500 patients who had IV TPA. Their mean door-to-needle time, the amount of time it took on average from when they arrived till they got their medication, was 86 minutes. For those who arrived in the first hour, it was a little bit longer, but 27% of those got treated, which is probably the whole group, more or less, 1 in 4. So a lot of people wash out for other contraindications, but probably the whole group that could did get treated. After an hour, we hustle. We got it done a little bit faster, but only 12% of those patients got treated. And this is the group where you miss them by just a couple minutes. And these are the ones where the protocol that we're talking about is so important. Because think about this scenario. A patient has a stroke. They wait for about 30 minutes. They decide their symptoms aren't going to go away. So they call 911. And the ambulance dispatched. So now we're 32, 33 minutes into the call. Your response time is, we'll say 20 minutes. So we're now 55 minutes into the call. So at 55 minutes, you do your first assessment of the patient. And you realize this is a stroke. This is a patient who can be who has an acute stroke, who could be treated. The problem is that what do we do next? We spend about 10 minutes on scene, so now it's an hour and 5 minutes. Get him to the ambulance. We start to transport. It's a half an hour transport. We wait till we're about 5 minutes out from the hospital. We call in with our report. It's now an hour and 30 minutes since the stroke. Hospital says, stroke coming. We'll see when they get here. They wait the other 5 minutes. And now we're at an hour and 35 minutes until the hospital starts to respond to that patient. Imagine if they'd have waited an hour or an hour and a half. Now we're so clearly outside of the window. But imagine instead, patient has their stroke, they wait the time, you get dispatched, you arrive, it's 55 minutes, you do your assessment and say this is a stroke, and contact the stroke center and say we've got a half an hour transport, but we're going to be coming in with an acute code stroke. Now they have half an hour to do all the things they need to do to be ready for the patient. And for some hospitals, that's critical because sometimes they have to call in a CT tech at night to do the CAT scan, or they have to turn on the CAT scanner to warm it up, or the nursing supervisor has to go to the pharmacy to get the medications. All these things can be done in advance. And so while we're not going to get the full 30 minutes back, we are going to save 5 to 10 minutes. And for this group of patients, that may be really what they need. So what hospitals in Maine are capable of treating stroke? All of them. All of them have CT capability. They have thrombolytics. And then the real issue is a willingness to do it. So when we look at our data from this region, from the catchment area for the stroke center, over the last few years, what we find is about a 1% treatment rate. So knowing that a certain number of our patients are going to wash out on time, and knowing that a certain number of our patients are going to have other exclusion criteria, we can estimate that 10% of all acute stroke patients are probably eligible for treatment. So that means 1 out of every 10 is actually getting treatment. That's a problem. We need to do something about it. And when we talk about our telestroke capacities in the region, we'll see how that's impacted this willingness to treat acute stroke. So what's the pre-hospital therapy of acute stroke? Frankly, there's not a lot we do other than identify it. And in Maine, we use the Cincinnati Pre-Hospital Stroke Scale. And we'll talk more about what that is. We determine the time last seen normal. Now, when we were developing this protocol, we went round and round about whether or not this was going to be an absolute rule-in, rule-out criteria for calling a code stroke. And what we decided was to make it not absolute, because I'll give you 2 scenarios. So I go to bed at 9 last night. I wake up at 6 in the morning. I can't move the left side of my body. When's my time last seen normal? 9 last night. I'm not eligible for treatment. EMS is called. I get transported to the hospital. It's now 6:30. My wife says, Jonathan went to the bathroom at 5:30 in the morning. And while he could probably hop if he had to, he probably would have noticed. So now my time last seen normal is 5:30, and now I'm eligible for treatment. So we didn't want to wash people out just because the history wasn't accurate. And it's through no fault of EMS, patients just don't always give accurate histories. By the same token, suppose I get up at 6 in the morning, I'm perfectly normal, or as normal as I ever am. I go to make some coffee and I notice I can't use my left hand. That'll go away, and after 20 minutes it does. So by 6:30 or so, I'm back to normal. Then at 6 at night, suddenly I have complete paralysis of the left side of my body. When's my time last seen normal? Well, I certainly wasn't normal after the event that morning, but that was a TIA. And so my TPA clock reset, and it started again at 6 at night. So if it's now 6:30 at night, I'm eligible. So we didn't want to rule that out. That group of patients, we wanted to basically say, if you are within 24 hours, let us determine that. Call them a code stroke and we'll sort it out when they get to the hospital. You want to rule out hypoglycemia. Patients with hypoglycemia can look exactly like acute strokes, and there are a few things more embarrassing and bad for patients than to let someone linger with a blood glucose of 12 until their labs come back, thinking the whole time that they've had a stroke because they can't move the left side of their body and they're aphasic. Then you treat their blood sugar, they wake up, and they go home. Now here's the most important part. As soon as you've made the diagnosis that a patient has an acute stroke, you need to notify the hospital so that everything we talked about can happen. So the Cincinnati Pre-Hospital Stroke Scale assesses 3 elements. It assesses speech. You ask people to say any phrase, but you can't teach an old dog new tricks is a good one. If patients say the wrong word, or they slur a word, or they drop a word, that's positive. You ask them to smile or show their teeth, because there are plenty of patients who say, I don't smile. Fine, tell them to snarl. All they have to do is show you the teeth. And what you want to see is whether one side of the face moves differently than the other. And finally, have patients close their eyes and hold their arms out. If one arm doesn't go up, or the arm goes up and then drifts down and they can't tell, or they can, but they just can't get that arm back up, that's abnormal. 1 out of 3 of those will identify about 80 to 85% of strokes. And if all 3 of them are positive, you can be about 95% sure it's actually a stroke. In Maine, we also do a mental status assessment. We want to know if they're lethargic, stuporous, comatose, and possibly even more importantly, we want to know if their mental status is changing. If you think about an acute ischemic stroke, you've got that blockage immediately. So if you're blocking off the consciousness center, within 5 minutes or so of the event, you should be completely unresponsive. Your mental status shouldn't change once you've had that stroke. It should be fairly stable. So if someone goes from awake and then 15 to 20 minutes later is unresponsive, that's very bad, and it means there's probably something else going on. All right, now that you know the background of our code stroke protocol, let's actually talk about what the Maine EMS Region 4 Code Stroke Identification and Notification Protocol is. Now, the goal of this protocol is to increase the number of eligible stroke patients who receive thrombolytics. So the strategy is for you to identify stroke in the pre-hospital environment. We notify the receiving hospital as soon as possible, and then the hospital will activate its internal processes. Now, this is an EMS-driven protocol, so we can't tell the hospitals what to do, but what we hope the hospitals will do is come up with a way of doing stat head CTs and getting those read, get the labs done that they need to, and administer thrombolytics in a timely manner. One of the things we have been asking hospitals to do is if their CT scanner is not available and diverting the patient to another hospital could get them there within the eligibility window, we've asked those hospitals to please divert those patients if at all possible. The only way that this works is for the EDs to know what code stroke means, and we've done quite a bit of education on that. We went to every hospital in the region and talked about this protocol. And then the hospitals have to respond to the EMS notification. These can't be patients who get put into a back room for somebody to see eventually. When you call a code stroke, there should be a response by the ED staff that shows that they want to get that patient evaluated as quickly as possible. We've seen with our code STEMI process that a collaborative protocol like this creates trust. If you follow it 100%, then that's what it'll do. People will trust when you say you have a code stroke, and these patients will get better care. We expect over triage, 30% over triage. We'll probably end up with about 10 to 15% because of our use of a 24 to 48 hour window for time last seen normal. and that's fine. We're okay with that. Now, this protocol applies to all agencies in Maine EMS Region 4, and it impacts all the hospitals in Maine EMS Region 4. So what is a code stroke? When you say that word, what does that mean? It's the identification of a patient with a stroke. There's 3 elements. The patient has symptoms that are consistent with a stroke. The patient has at least one positive finding on the Cincinnati Pre-Hospital Stroke Scale, and those findings are new within the last 24 to 48 hours. If that's the case, assess their mental status, do a fingerstick blood glucose, rule out that hypoglycemia, and that's your code stroke. And so based on this, a Maine EMS EMTB who has taken the blood sugar monitoring course could identify a code stroke. The key there is that you can rule out hypoglycemia. Early notification is critical. Now you can use any language you want, but this little phrasing here has been handcrafted, many hours put into it. This is XYZ EMS. We are transporting a 47-year-old female patient, code stroke. Patient was last seen normal 40 minutes prior to our arrival. Cincinnati Pre-Hospital Stroke Scale is positive for one of 3 elements. Patient is unable to hold up her left arm. Patient's mental status is alert and oriented. Blood glucose is 72. Vital signs are heart rate of 78. Blood pressure 142 over 56, respiratory rate 12, oxygen saturation 98% on 2 liters nasal cannula. Our ETA is 15 minutes. We'll give you an update when we're 5 minutes out. Do you have any further questions or orders? And that's all the information a hospital would need to spin up its code stroke process. Other data that's useful to collect: if the time last seen normal witness, that is their spouse or whoever saw them normal, isn't coming in the ambulance with you, get a name and contact information, because oftentimes there'll be some question about when really was their time last seen normal, and then we can't get in touch with that person and the patients fall out of eligibility. If you can, complete a TPA checklist, time permitting. Don't if you don't have the time. And then do your usual sample history and OPQRST history. How do we treat stroke in Maine? Well, this is the 2008 stroke protocol. Essentially, we don't treat the stroke. You manage the airway as needed, and then you identify hypoglycemia. You fix it. Now, can patients be having a stroke and be hypoglycemic? Absolutely. So, if the patient's hypoglycemic and has stroke symptoms, treat their hypoglycemia. When their blood sugar normalizes, those stroke symptoms should go away. If they do, then it was just hypoglycemia. If they don't, it's still a code stroke. Between the intermediate and the paramedic, all we really add are more aggressive ways of treating hypoglycemia. There's not anything else you do for the stroke. Don't give aspirin because, again, you don't know if this is a hemorrhagic stroke or not. On arrival, give your bedside report. If you didn't bring the time last seen normal witness with you, give that contact information. And if you did a TPA checklist, give it to the staff. The hospitals have developed plans to respond to patients. One of our hospitals in the region actually meets the patient at the ambulance bay with a stretcher and takes them directly to CT scan. They have the clinician meet the patient in the ambulance bay as well to do a quick assessment. All the hospitals have made plans to one degree or another on how to respond to you saying this is a code stroke. So the hospitals then will get their imaging, get that imaging interpreted, get the labs they need, and give the thrombolytics. If they need consultations, they can contact the transfer center and ask for the stroke neurologist, and that'll help both with the management and with arranging the transfer.